Good morning, everyone here in the U.S. Afternoon to everybody in the U.K., Ireland, and elsewhere. My name is Karen Anderson. I am a type A dissection survivor. I'm also the president and one of the founders of the nonprofit organization in the U.S. here called Aortic Hope. We are a support patient advocacy organization, and I'm also the president of Think Aorta US, which is a wonderful opportunity to share and spread some awareness here, thanks to the efforts of Think Aorta out of the UK and Ireland. And we're so excited to be able to offer you this webinar this morning, which is all about aortic dissection in pregnancy. We have such a wonderful panel of presenters today, and I wanted to welcome all of you. And we do have Gareth Owens from Think Aorta as well with us today. I'm going to take a minute and just share with you some information about Dr. Stephanie Curtis. And from there, we're going to listen to her presentation, and then we will talk with survivor Halima Sadia. And then we're going to open it up to questions. So if you're live with us, feel free to type your questions in. There's also a link to do that anonymously. And if you are seeing this on replay, you can still ask questions as well. Please like and share this video, and we will always have an opportunity to get back with you and answer your questions. So good morning, everyone. Welcome. Nice to see all of you. Okay, let's get started here. So Dr. Stephanie Curtis is a consultant cardiologist and subspecialty lead for adult congenital heart disease and maternal medicine at the Bristol Heart Institute. She's the lead cardiologist for obstetric medicine at University Hospitals Bristol, which is a service run jointly by cardiologists, obstetricians, and anesthesiologists, providing care for pregnant women with heart disease across the southwest of England. Dr. Curtis is particularly interested in all aspects of maternal cardiology, from contraception and pre-pregnancy counseling to the care of the pregnant woman with heart disease. She is also interested in inherited heart and muscle disease and diseases of the aorta, such as Marfan Syndrome. She was an invited speaker about maternal aortic dissection at Aortic Dissection Awareness Day UK 2021, and she recently co-authored a paper in the journal Heart titled Aortopathy, did I pronounce that correctly, in pregnancy. Not sure if I put the emphasis on the right syllable, but I'm sure that you can correct me on that. Thank you so much, Dr. Curtis, and welcome.
Thank you so much, Karen, and thank you, Gareth and Halima, for asking me to talk. I'm absolutely delighted to be with you and feel very honoured to be invited into your Think Aorta family, who are doing such fantastic work globally, really, in the UK and, of course, everywhere in the world. Now, I'm going to attempt to share my slides, which I hope will work. So I should be on the first slide. Does that look okay? Yeah, okay. All right, so for the next sort of 15, 20 minutes or so, I'm going to talk about maternal aortic dissection, so an extension of aortopathy, I suppose. So this is kind of worst case scenario of what happens when your aorta is diseased. And the first thing to say about this, I know that many of you who are watching this know a lot about these conditions already, but I think it's really worth reminding ourselves that this is a pretty nasty condition and results in maternal death. In every maternal death inquiry in the UK, these are the numbers from it. For many, many years now, it has been a consistent feature. There are other conditions that go down in terms of their prevalence, but aortic dissection really hasn't changed. And in this chart, you can see over the last 25 years or so the numbers, and the line that you see is the maternal mortality rate. So it is drifting down, and yet dissections occur in about 11 to 15% of deaths that are reported, and this really isn't changing, and we need to think about how we can do something about this. So this is data from America, from Alan Brevham. It was published about a year ago, and we get this every so often from the International Registry of Aortic Dissection. So these were the pregnant ones. So this is not a common thing. There were 29 women in this study over about 20 years. Who dissected. But the important thing about this, and I think this is the key thing to take away, and the thing that I know that Think Aorta have been working on very hard, is increasing awareness of this. And 47% of the women who dissected in this registry were unaware that they were at risk. If you actually look at some of the Marfan data, so Marfan syndrome is the thing that's been studied the most, I would say, in aortopathies in general, but definitely in aortopathy in pregnancy. And these are 4 of the biggest studies in this. These are small numbers compared to a lot of cardiology studies, but pretty big for aortic dissection in Marfans. But you can see if you look in the right-hand column that about 2/3 to 3/4 of these women didn't actually know that they had the condition. Now, it's fine to not know perhaps that you have an aortopathy, but Marfan's comes with a whole load of skeletal features, so it's quite astonishing really that so many women didn't know that they had it. We'll talk a little bit about that later. So it's a little bit about trying to make people aware of what they don't know These are the wildebeests being stalked by the lions, so they're completely oblivious. But if they knew that there was a lion there, then any little movement in the grass would make them run. But these wildebeest are a little bit like the women who don't know they have an aortopathy. They really don't know that they might be eaten at any moment. So if you want to think about aortopathies, the way I think about it is two sort of broad groups, and this is what I try and explain to patients. So there are the syndromic types, and these are people who look as though they may have something else going on with their connective tissue. So they are tall, thin, with long fingers, perhaps twisted spine, scoliosis, flat feet, and so on. And the most common thing that we see, as I say, is Marfan syndrome, so caused by a pathogenic variant in fibrillin 1. Louis-Dietz, which is less common and was discovered not that long ago. The classic triad of Louis-Dietz is the bifid uvula. I don't know if anybody's ever looked at their uvula, but it don't look like this. This is not normal. So this has got two parts instead of one. You don't see it in all Louis-Dietz, but they sometimes have funny shaped uvulas. And also arterial tortuosity and hypertelorism, which is when your eyes are quite far apart, although it's not always seen, and many of the patients look as though they have Marfan's actually. But now we know there are 5 genes, and pathogenic variants in these genes can cause Louis-Dietz, and initially there were only 2. So it really is a changing field all the time. Many of our patients with Marfan's have been re-diagnosed as Louis-Dietz over the years. And then there's vascular Ehlers-Danlos, which is caused by mutations in pathogenic mutations in COL3A. And this is a very, very rare condition, very aggressive aortopathy. And then there's the non-syndromic ones. So these are in patients who don't look as though they have the connective tissue abnormalities like some of these other conditions. And this is quite common actually, but it has reduced penetrance. So in other words, if you have the pathogenic variant, you won't necessarily develop the condition to the same degree as some of your other relatives. But there are lots of genes involved here, and the panel that we look at, or the genes that we look at when we're doing our aortopathy panel, is 32 genes. So it includes all of these ones, but quite a lot more that come into this non-syndromic category. And then, of course, there's the bicuspid aortopathy. So bicuspid aortic valve disease is very common. It affects about 1 in 100 of us, and people have about a 90% risk of enlarging their aorta throughout life. But quite often it's fairly benign, and many of them won't need to come to surgery. But there are some that have an aggressive aortopathy, and those are the ones that we need to look out for. So again, if we look at our Braverman, if you remember, data over 20 years with our patients who dissected in pregnancy, most of them were Marfan's actually. And that's because of the prevalence really of Marfan's and the mix of the prevalence and the pathogenicity, I guess. Then we got the Louis-Dietz, we've got some bicuspid aortic valves, those with a family history of aortic dissection. So those are the non-syndromic hereditary thoracic aortopathies that know there's a family history. And then there are the non-syndromic hereditary thoracic aortopathies who actually have the condition. There were no Ehlers-Danlos here, mainly because they get told that pregnancy is really a bad idea for a lot of reasons. But interestingly, 69% of these patients had either an aortopathy or a family history. So it is really hard to imagine why they were in a position where they were unaware that they were at risk, if you like, or 47% of them were. So the question, I suppose, the first thing I was thinking of, or when I started thinking about all this back in the day, was, does pregnancy actually increase the risk of dissection, or do people just dissect anyway, and whether they're pregnant or not is just, an incidental finding? Well, this has been looked at in one study, which I'll show you in a second, and theoretically we think that there might be a substrate for this. So we know that estrogen and progesterone can affect the aortic wall, and we know that the hemodynamic changes of pregnancy are things that the aorta doesn't like, so tachycardia. Classically, an increased cardiac output, all of these things increase in pregnancy and around the time of delivery that you can see in the end of this little graph in the middle. I'm not sure, I can't seem to produce an arrow here, but that's fine. But the point is that towards the end of pregnancy, the stroke volume is really very high. There's a lot of blood going through the aorta, and the heart rate is quite fast. And the blood pressure, which drops early on in pregnancy, due to the placenta being a low resistance organ, so the SVR drops, the blood pressure gradually creeps back up to normal. So around about this time, blood pressure's coming up, patient is tachycardic, then of course they go into labor, and they do the Valsalva maneuver when it comes to pushing. Labor is very painful, so the blood pressure is up, and every time you release that push, you get a rebound tachycardia and hypertensive response. So it's a bit of a perfect storm, really. And then when the placenta comes out, In developed countries, everybody gets an injection of something like ergometrin, which is a very powerful vasoconstrictor to stop the bleeding, but of course it rapidly increases your blood pressure. So all of these things lead to an increased risk of dilatation and dissection. And this is a study that I kind of jumped to a little bit too quickly there, but this is a nice crossover population study from the States looking at 6.5 million pregnancies, a crossover cohort study, then looked at them a year later and looked at aortic events. And compared to the study period in terms of pregnancies, there were 36 dissections compared to non-pregnant controls. And this is in inverted commas, normal people. So the feeling is that pregnancy itself increases your risk of dissection by about a factor of 4. And then what about in Marfan's or other connective tissues? Well, we don't have enough diseases. We don't have enough data on many things, but we have quite a lot on Marfan's. I'm not going to show you all of it, but generally speaking, the feeling is that if you compare Marfan's to non-Marfan patients who are pregnant, the risk is about 8 to 9 times higher in pregnancy. So if you imagine multiplying that perhaps by the 4 times risk that exists between normal, inverted commas, and pregnant, you might get a sort of 36 times higher risk of dissection, which of course is still rare. So that leaves patients thinking, well, okay, all of these numbers, what do they mean? I don't tell them all those numbers, but putting them into context, around 3 to 4 in 100 of Marfan's pregnancies, women who are pregnant will dissect. But that is all comers. So that includes all of those people who didn't know they were at risk. And what I say to women who are coming along for pre-pregnancy counselling is that they're kind of the winners, if you like, insofar as they know they're at risk. They're going to be watched very carefully. They're going to have their labours managed very carefully. And we advise them to stay in hospital for longer after delivery and things like that. So their risk is actually probably lower. But there's some people who will have higher risks, and I'll talk about that a little bit in a second. So just recapping briefly, you know about type A and type B dissection. So type A dissection is the seriously life-threatening one, although they both are involving the aortic root, which can then tear off the coronary arteries and cause a hemopericardium and death very quickly. And then type B dissection further down the road. And in terms of what happens in pregnancy, there's about a 60-40 split between type A and type B. And in terms of antenatal, postnatal, it's quite interesting because postnatally it is more common. So this is quite common in a lot of things in pregnancy, pulmonary hypertension, heart failure. It's worse afterwards because a lot of the changes go back to normal. They revert very quickly. The fetus is taken off the abdominal aorta. So there's a big rush of blood back to the heart, increase in preload. The contents of the placenta, about half a litre of blood goes straight back in the circulation. You get a massive surge in a cardiac output and blood volume at that time. And interestingly, the median time for dissection in the Marfan's patients is about 6 days if you look at all the big trials. And so we advise people to stay in hospital for 7 days afterwards, which they're never massively keen on when you're giving the counselling in advance. So I always tell them this in advance. It's entirely up to them whether they do it or not. But I tend to say, unless you can see the emergency department's door from your front door, you're much better off being in hospital because, as Karen will know, and Halima will know, and many people who have suffered aortic dissection, time to surgery is the life-saving thing. So if we look at the Braverman data again, if you remember me mentioning at the beginning this aortic dissection data that we have most recently in pregnancy, a little bit less type A, so 45%, a little bit more antenatal, but you can see here the mean time to dissection was 12.5 days postpartum. So women need to be aware that this can happen a little bit down the line. Other people who are at risk, family history of dissection is important, and size is really massively important. And if you look at the women who dissected here, they had big aortas. So 55 millimeters is a big aortic root and ascending aorta. And in the type Bs, the descending was 33, which is still quite big. But we would send people with Marfan's to surgery at 50 millimeters or 45 if they had high-risk features such as a family history of dissection or rapid growth, or if they wanted to have a child. And the important thing also to say about type B is that it is totally unpredictable. So you can have a normal aorta, particularly a normal root, and type B can come out of the blue in pregnancy or any time, in fact. So knowing all of this, what do we actually do to reduce the risk and try and help these women? Well, the pre-pregnancy counselling is absolutely crucial, and I'm sure Halima will mention this as well. What I tend to do with the women is suggest that we have some up-to-date imaging. So we need a full aortic MRI. We do look for dural ectasia as well, because that's important with regard to epidurals and so on. And then try and work out that individual woman's risk of dissection. And then talk a little bit about the baby, of course. So it's at 50% risk for most of these conditions, and explain to them the possibility of pre-implantation genetic diagnosis. So that's where you make lots of embryos, and then you test them for the pathogenic variant, and then you only implant the healthy embryos. And the important thing also is to talk about the medications. So they may be taking angiotensin receptor blockers such as losartan and beta blockers. The beta blockers are absolutely fine to take during pregnancy, but losartan and the angiotensin receptor blockers are not safe in pregnancy. So it's really important that they know that they should not be taking them, and they need to stop them prior to getting pregnant. Ideally, if they become pregnant on them, that's fine, but they need to stop them immediately after that. And the other thing just to mention, and it's really important to talk about multivitamin, smoking, weight reduction, things that are just good things to talk about when you are, I'm just going to close the door because my children have just come home from school and I forgot to send them a text telling them not to make any noise. To use this as an opportunity really to talk to them about healthy pregnancy, and there are many things that need to be addressed. So during pregnancy, it's important that they know they're going to be coming to the hospital a lot. So 4 weekly echoes is what we recommend, and additional growth scans if they're on a beta blocker. So we do tend to continue beta blockers during pregnancy. They make babies a bit smaller, maybe about 200 grams lighter. And then when it comes to the delivery, I don't go into this in a lot of detail if women aren't imminently planning pregnancy, but it's important just to say to them, you know, we talk about, we're going to talk about a passive delivery. So you're not going to have pain and you're not going to have pushing. And, you know, the whole pushing the baby out, being in agony for 24 hours, way overrated. Get, you know, a copy of War and Peace, or, you know, Hello Magazine, or whatever you want to read. Sit back, enjoy it. Because every time you have one of those contractions and you're in severe pain, your aorta will not be thanking you. So they have an epidural, and then the contractions themselves will actually push the baby's head down to the perineum, and then you can just lift it out with forceps. So you don't actually have to push at all. You can't get it out with Ventouse, though, because Ventouse does involve some pushing. But we've had many patients deliver this way, and we've studied our complication rate, and it's not increased with using these techniques. The other thing that's really important is the postpartum stay. And as I mentioned to you before, the median time of dissection in Marfan's is about 6 days. So it's really important that patients stay in afterwards. And I try and sell it to them about the nice rooms and the good food. But it doesn't usually work very well. But genuinely, they can get more help with breastfeeding. And also they can get a little bit of sleep and a little bit of support and get their meals made for them. So it's not the worst thing in the world. And some women go, right, fine, I'm just going to, you know, it's like prison for 7 days, I'm just going to do it. And then importantly, the baby needs to be seen and pediatric follow-up instigated with the pediatric Marfan services. And then the follow-up with the woman's also important. So we do a postpartum echo and then about a 4 weekly echo, and we keep a close eye on them for about 6 months afterwards until they go back to their routine follow-up. And the other thing that's important about this is there is no point starting this when people are 18, 19. I've had many, inverted commas, fallouts with parents when new patients have come at the age of 17, 18, and I start talking about pregnancy, and they say, you know, she's still at school. And I say, yeah, well, you know, do you know what she's up to in her free time? But people get pregnant unplanned pregnancies all the time. In most people, actually, pregnancy is unplanned in the UK anyway. And so they need something to be said to them early on, even if it's just along the lines of, it's fine, but it's high risk. Don't get pregnant by mistake, and have some pre-pregnancy counselling. And if you genuinely really do want to get pregnant, then come along. And then as I get a little bit older, so not the first time I meet them, but maybe the second time, I'll say something like, it's high risk. We're going to recommend a passive delivery and an epidural, just in case some of their friends start having babies and saying, you know, don't have an epidural because it's, you know, poisonous and dangerous and all this sort of stuff. So all that stuff we go through. When it comes to people being pregnant, it is a senior clinician job. These are rare conditions, so we have consultant or obstetricians, anaesthetists, and cardiologists in our cardiac antenatal clinic, and we've been running this clinic now for more than 20 years, and we have a team that are really well practiced together, and we have an antenatal and a perinatal and or antepartum, a peripartum, and a postpartum delivery plan for all of them. We tend to follow this sort of pattern. So you can see the lowest risk patients are at the bottom. I'm not going to go through all of this, but the highest risk are at the top. So the BAVs with the smallish aortas, we don't worry about too much. But when it comes to the Marfans with the big aortas, we always beta block them. We scan them regularly. We go for a passive delivery, and we do an elective section in ones where we think we might need a cardiac surgeon. We want to recover them on CICU because that's our cardiac ICU, because we don't want them to dissect in a maternity hospital, which is slightly separate, a separate building, which is often the case actually. So just to finish off, really, I'm just going to mention a little bit of research, which is fascinating. This is the Marfan mouse, which has given us a lot. It gave us losartan, it gave us Louis Deeks. And the Marfan mice, if it gets pregnant, 90% of them will die within the first 4 weeks postpartum, which is pretty tragic. But if you remove the pups at birth, this death rate drops to 26%, which is really quite dramatic. And if you give them an oxytocin receptor antagonist in the third trimester, this risk will drop to 6.7%, and they get to keep the pups. It's animal experiments for you. And this is really fascinating because oxytocin, what has oxytocin got to do with it? The problem with oxytocin, of course, is that it is what induces the bonding and the breastfeeding and the letdown response and so on. Is breastfeeding a risk factor for dissection? I'm very interested in this, but it's very difficult to do a study on this because the event rate is low and a lot of women try breastfeeding for a bit. Most do really, but then they stop. So it's difficult to really tease out what's going on here. But there is a theoretical mechanism for this because oxytocin is caused, the expression of oxytocin within the tissues is facilitated by something called ERK, which is endothelin, which is extracellular signal regulated kinase. Yeah, just think about that for a minute. And ERK is a nasty thing in the blood, and it's a bit like angiotensin 2, which causes a lot of vasoconstriction and other nasty things. And if you block ERK, these mice don't dissect, and if you block ERK with a drug called hydralazine, they don't dissect. And hydralazine is a drug we use for high blood pressure and heart failure. It's very old, but it's very effective. I've got a patient on it at the minute who's pregnant with heart failure. It gives you headaches, but it's pretty well tolerated. But there is a possibility that this might actually be something we should be using going forward. So reminding you all, think aorta, you all know this, but the awareness, I think, is really the way forward. I think emergency departments are doing a great job with this, and Emma Redfern, I know, is leading this in Bristol for us. And people just go straight to CT now, and it's massively important. So just my final slide really is just to say it's totally a team effort. My obstetric colleagues are top left there, my cardiology colleagues, anaesthetists, fetal medicine team, and the clinical geneticists. Now, I think we're going to go straight on to Halima, and I would just warn you to get your tissues out because this is pretty powerful stuff.
Thank you so much, Dr. Curtis. I'm actually on a second piece of paper because of all the questions that I have, and I did not dissect during or after pregnancy. So I love when we can have these webinars because I'm still 7 years later always learning, and I love learning. I think it's so important. I don't think you can learn enough about this disease. So I thank you so much for sharing all of your information. Okay, like Dr. Curtis said, have your tissues in hand. We have Mrs. Halima Sadia, who survived an acute type A aortic dissection during pregnancy at the age of 21. She has told her amazing story of how she and her daughter survived against the odds at several major conferences over the last 2 years, raising awareness of aortic dissection in pregnancy. Halima is interested in highlighting the important issue of aortic dissection in pregnancy, improving management of it, and providing better information for women at risk. In October of 2021, she was elected vice chair of the National Patient Association Aortic Dissection Awareness UK and Ireland and became a co-leader of the global Think Aorta campaign. That's so wonderful. Thank you so much. Halima, tell us your story.
Thank you so much for such a great introduction. First of all, thank you to everyone for joining us. As always, I'm really honoured to be able to speak here today. And like yourself, I've learned so much from Dr. Stephanie. I've heard you speak about this issue before. When I first heard you speaking, a lot of the things that went through my mind was, why was I not given this care? But at the same time, I am so grateful that people like yourself are spreading this awareness and making sure that vital care is given to patients. So now obviously I'm just going to share the story of how an aortic dissection nearly cost me my life and the life of my daughter. So in May 2017, I had an aortic dissection whilst I was 15 weeks pregnant. I was at my parents' house freshening up when suddenly I began feeling a sharp onset of stabbing pain on my back. So at first I tried to ignore it and I continued washing my hands, but then it became so unbearable that I fell to the floor in pain. My mum and my husband helped me off the floor and onto the sofa. The pain became so excruciating that I began vomiting. I was crying out and it felt like my insides were being stabbed with a knife. So my family called for an ambulance. The paramedics checked me over and they decided to take me to the local hospital due to the fact that I was pregnant. So I was taken to the A&E department, and by the time I got there, I was in so much pain that I wasn't able to sit down or lie down comfortably. I couldn't even stand. I was just so uncomfortable that I was crying out in pain. So after initial assessment, I was told by the nurses that I was actually completely fine, to stop making a scene, and I was told to sit and wait for a doctor. So my family obviously continually requested for further assessment, but this was ignored over the following hours as I waited. So my own initial thoughts were that something had happened to my baby, and due to that, I was being affected. So when I was finally seen to by a doctor, I was administered morphine, which helped the pain subside, and I fell asleep in this state. So when I woke up, I was told that I would be moved to the women's unit for observation, as it was presumed that I had kidney stones and that there was something wrong with my baby. So over the next 24 hours, I was kept under observation, and in the early hours of the 15th, that was the day of my mum's birthday, my condition deteriorated to such an extent that I began coughing up blood. A specialist was called, who, upon listening to my breathing, realised that something was terribly wrong. The nurses ran observations and realised that my oxygen levels had dropped significantly. I was taken to the delivery suite, to a room full of doctors and consultants. My husband counted over 15 doctors standing around me. They were all trying to figure out what was wrong with me. My family were called and they were told that I had pneumonia. So I was told that my condition had become very serious and that I would need to be sedated. The last thing I remember that night was my husband holding my hand, telling me that it was going to be okay. I gave him my wedding rings and we said our goodbyes. In my mind, I thought this was our final farewell and that I probably wouldn't see him again. I pulled a brave face and agreed to them sedating me. I was transferred to intensive care. I was placed on life support and my family were told that I potentially had a few hours left to live. Scans were taken and finally, after over 36 hours, a CT scan, I was given a CT scan and an official diagnosis of the aortic dissection was made. By this time, my entire family had gathered at the hospital as they thought that I wouldn't survive. The doctors pre-warned my family that it was unlikely that my baby would live. It was decided that I was going to be transferred to the Queen Elizabeth Hospital in Birmingham, as they have a special intensive care cardiac unit. My family were told that this journey itself could be fatal due to the fragility of my condition. Upon arrival and still heavily sedated, I was transferred to the care of the cardiac unit, and once stable enough, I was taken to theatre and had my surgery that lasted for over 10 hours. So my operation was a success. My entire aorta had dissected, but only the root and the arch had been repaired. My valve had ruptured and was replaced with a mechanical one. My family were told that my baby daughter was alive and that she even had hiccups throughout my surgery. I woke up 4 days later and I was very confused. My parents sat beside me and told me what had happened. It came as a huge shock. I didn't really know what to think. I was very grateful that my baby was alive, but I was so confused about what had happened. One moment I was getting ready for a vacation, and the next I found myself fighting for my life. Over the next few days, I began making progress, and so they moved me to a ward. However, just after 3 hours of being on the ward, I began to feel really unwell again. I had chest pain and I was feeling very weak. A scan discovered that a clot had formed, so I was rushed back to theatre for another operation. I spent another week in intensive care, making slow and steady progress, but on the morning of the 27th, the day of my 1-year wedding anniversary, I felt that something was wrong. I was struggling to breathe. A scan showed that another clot had developed. I was alone at the hospital as the visiting hours hadn't started yet, and I remember calling my family, telling them what was happening. I remember feeling really upset and hating my life. It felt like I was never going to get better, and I felt like I'd ruined our first wedding anniversary by being so unwell. This second clot meant that I had to go into for surgery for a third time. I spent another week in intensive care after that, after which I was discharged from hospital. It finally felt like things were going to get better. I felt really happy that I was able to go home. Although I had a really long way to go for recovery, I felt that being at home gave me the time and the comfort to prepare for the birth of my baby daughter in a more private setting. Unfortunately, this dream was also cut short when I woke up 2 days later with a sharp pain in my chest. It was excruciating and similar to the first time that I went into hospital. An ambulance was called and I was taken to the local hospital again by the paramedics. One of the nurses there thought I was in labour, but scan revealed that I had developed a cardiac tamponade, and so I was transferred to the Queen Elizabeth Hospital again for further surgery, making this my 4th theatre visit. The bleeding was so heavy that they had to pack my chest and leave me open overnight. The next day I was taken back into theatre for the 5th and final time for them to close up my chest, and thankfully that was a success. So the final operation affected me the most. It physically affected the most as I lost the use of my legs. I was unable to walk for weeks. I had extensive physiotherapy whilst I was in intensive care, and it felt like it was the worst time of my life. I felt like I'd lost all of my dignity as I was completely dependent on the nurses and my husband's help doing everything. I felt completely helpless as I couldn't even go to the bathroom or have a shower without assistance. It really damaged my confidence. This is when I began to realise that my life was never going to be the same again. After many weeks of being in this situation, I started to make better progress. For instance, I slowly started to learn how to walk independently again. And after a few weeks, I was discharged from hospital. This, thankfully, was the end of my major operations. The week after I was discharged, my brother got married. I attended his wedding with a walking stick. I was 7 months pregnant and I was struggling a lot. Everyone was complimenting me and congratulating me on my progress, but deep down, I felt like I was in a really dark place. I felt like the odd one out because I couldn't walk without the help of a stick. I had huge difficulties both sitting and standing because I had a large hematoma on each side of my groin. I was uncomfortable doing anything, but I decided that I was going to fight this and overcome this, as I needed to be strong for my baby girl. Sorry, this always makes me feel really emotional. She was my motivation, and the only reason I got through it was because I wanted to be strong for her. So once I started to show really good progress, the doctors focused on their efforts on my daughter. A scan revealed that something was wrong. Her blood supply had been cut off when I was on life support, and so her bowel hadn't fully developed. I was heartbroken when I found out that my baby girl had suffered due to my illness. Sorry. I felt really guilty, and it felt like it was my fault, as she would have been okay if I didn't have an aortic dissection. So many thoughts crossed my mind, but ultimately I knew that I had to put my feelings aside and put my energy towards her. At the same time, I had to prepare for the worst. During my time at the hospital, the doctor spoke to me and said I should terminate my pregnancy because the effect of the pregnancy was making me even more poorly. But I refused, and I said if it was meant to be, she would go, but I wasn't going to kill her. I endured all the further pain because of the strain of the pregnancy, and so when I found out that her life was at risk, I was heartbroken and I didn't sleep properly for days. I was having scans 3 to 4 times a week, and the travel back and forth to and from the hospital put a huge strain on my health. However, I didn't give up for her sake. As my due date neared, I'd had a discussion with the doctors, and they said it would be best if I had a planned C-section with a cardiac team on standby. I would be in no fit state to give birth naturally. Unfortunately, this didn't go to plan either, as I went into preterm labour 2 weeks before the planned C-section. I was 32 weeks pregnant when this happened. The pain was intense and my condition deteriorated. The doctors were unsure whether to take me to theatre, as I was supposed to have my C-section with a cardiac team on standby. I was told to prepare for both outcomes. I sat there crying, and I told my baby that whatever happens, I will always love her and that she was the best thing that ever happened to me. It was the first time in my life that I felt so alone and scared. I knew that our separation was near, and I didn't know how I was going to cope. I informed my family, and they came, and we said our goodbyes before I went to theatre. My daughter was born at 3:56 in the morning on the 4th of September. I'd lost two litres of blood during the operation and was unwell once again. When I woke up, I felt like my heart had been ripped out. I was devastated. My daughter was taken straight to the neonatal unit and was intubated at birth. We were no longer together. I didn't meet her until the next day. This was the most painful thing that I'd ever experienced. When I finally met her, I broke down. She was the most beautiful thing that I'd ever seen. I named her Ruqayyah. I can't find any words to describe how it felt seeing her lying there in an incubator, relying on machines to breathe. I couldn't even hold her. I could only touch her through the little doors of the incubator windows. We don't have time to go into full detail about her full stay in hospital, but just to summarise, she ended up spending 10 months in hospital and went to theatre 11 times. She had multiple laparotomies and surgery on her bowel. Before she was discharged from hospital, my husband and I were trained on parental nutrition, and I was also trained on how to pass an NG tube, as she was relying on this to live. Despite everything that she went through, she's currently doing really well. Sorry, I've got my box of tissues with me as well. Despite everything that she went through, she's currently doing really, really well. She's now 4 years old and is the happiest girl I've ever seen. She has a central line and her progress has been absolutely amazing. She really is one of the bravest and strongest person I know. Having defied all the odds, I believe that she is a true miracle. One of the most difficult things about being Ruqayyah's mother is the burden that I feel on myself and the guilt that I carry. It hurts me to know that this pain that she goes through could have been prevented. One of the main reasons that I'm speaking here today is to make sure that no one in my situation is neglected. I would do anything in my power to prevent a mother from going through what I had to go through. People assume that I knew what would eventually happen with my heart condition, but the truth is I absolutely had no idea. The fact that my mother, who also suffers from Marfan Syndrome, had 9 healthy pregnancies made me completely oblivious to the fact that having Marfan Syndrome and being pregnant could make me, could almost kill me. If I went on Google now and if I typed in aortic dissection symptoms, all of the symptoms that I had would come up. To this day, I find it really hard to understand why it took medical experts over 30 hours to diagnose me. I can't help but think that my daughter's condition would have been different had I been treated sooner. I want to ensure that the next time a pregnant woman walks through the doors of an A&E department with any pain or any issue, that she's treated properly without being dismissed or ignored or being told that she's causing a fuss. I honestly believe that there should be more awareness of how life-threatening a pregnancy can be. I want to spread awareness to make sure that every single person is taken into account. There are so many men and women out there who have had to go through huge struggles due to their symptoms not being taken seriously. So on behalf of everyone who's had an aortic dissection, I want to make sure and help ensure that situations like ours are prevented. I wouldn't be here without the support of my family, especially my husband. I don't think any man has had to go through what he has had to, in their entire life, let alone in the first year of marriage. He sat with me every single day and he showed nothing but bravery for both me and my daughter Ruqayyah when we were going through our struggles. He never gave up, and he even finished his university dissertation at my bedside in intensive care. Having an aortic dissection has not only changed how I live my life, but it's changed me as a person. I live each day as if it is my last, and I try to grab every single opportunity that comes my way because I want to be the best version of myself for my daughter Ruqayyah. I never ever want her to feel alone or scared by whatever life throws at her. She inspires and motivates me more than anyone. I'm so proud and honoured to call her my daughter. Although sometimes I come across as a really brave and strong person, but I do have ongoing struggles almost 4 years later. Sometimes I lay awake at night listening to the sound of my valve, and in my mind I go through what's happened. Sometimes the sound is so loud that I can't even sleep. I haven't fully come to terms with it just yet, and I hope that by helping other women, I too can start to feel good about everything and turn all the negatives into a positive. I want my scars to become the symbol of my strength and not my weakness. And I want the ticking sound of my heart valve to be a reminder for me to go out there and help people. I'm here today to help and support and maybe inspire somebody and make a positive difference in the life of others around me. And as Karen mentioned earlier, since becoming vice chair, my main focus has been spreading awareness not only of aortic dissection, but aortic dissection in pregnancy. And so I've been very honoured to be able to work with Dr. Stephanie Curtis, and we've recently worked together to produce a patient leaflet to help women at risk of having an aortic dissection in pregnancy. And we will email everybody about it when it's ready to be published. I want to take this opportunity again. Thank you so much for all being here today and allowing me to share my story with you.
I'm usually not one that's left without words, but I'm trying to, I'm just trying to think of the words to say. I think all of us who have had an emergent situation, plus those that find out they have an aneurysm and they're watching and they're waiting, I think that we all sit and wonder when that next shoe is going to drop. You must have had a closet of shoes, because I'm listening and I'm losing count of how many times you ended up in the hospital. And I'm not even going to ask. You must wonder. I'm assuming you must always wonder, because we all do. When's the next thing? What's that ping and pang I feel? Is this something else? I am not only inspired by your story, I think that sharing survivor stories validate other survivors. They validate other caregivers. It validates even people who this hasn't happened to. It validates people who have had other medical situations. It reinforces our emotional feelings that they are valid, they are real, it is normal. And I appreciate the work that you're doing so much. And as you're talking towards the end, my mind is spinning on additional ways that we can increase this awareness that you can bring to the community. And you are one bad bleep woman. Your body is incredible. It's amazing what you have been through, and to see you sitting here as a beautiful, strong mother, woman, wife, advocate. I am proud to have been able to have a chance to listen to your story, and I thank you so very much.
Thank you so much.
That's incredible. Because I say I'm at a loss for words, but I haven't stopped talking. I am going to open this up now to questions and comments. I'm going to hold mine for the end. So let me check and see what questions we may have. Okay, so to make sure I have this question right, can you let me get that again one more time. Mm-hmm. Is preconception genetic testing for a patient that has a history of TAD becoming more common practice? I guess this would go for Dr. Curtis.
This one's for me, I think, isn't it? Thanks for that question. It's a very good question, actually, which is I'm going to try and give a short answer because I do like this subject, so I can prone to waffling on. The short answer is yes, it is becoming more common. But if you have a family history and you don't have the condition, then we don't genetically test predictively people who are normal. So we need the proband, that means the person who had the dissection or the aortopathy, and we need the gene from them. And then we will check that person for a gene. So if you're a woman who comes along and says, my mum died of a dissection and there was no DNA kept, then we can't do anything. And we get this all the time, actually. And it's a very difficult conversation about risk, which probably the longest conversations I have, actually. But if sometimes we can actually get DNA, or we can get the autopsy report and we can find out that actually there was a bit of DNA stored, and then we can test that. But then we test the person. So we don't do pre-genetic testing like pre-implantation diagnosis in somebody who's healthy. We will test them for the gene. But if they have a normal aorta but they have the gene, then for sure. And it is definitely becoming more common because it's becoming more accessible. And in our country, it is free on the NHS, which is quite important because otherwise IVFs are expensive.
So a follow-up question to that, if in generally speaking, if you have a family member who's had a dissection and let's say they don't have a known genetic cause or reason. And here it is, that's your mother. Let's use your example. And I'm going to get pregnant, or I am pregnant. Wouldn't it make sense to at least just do a baseline echo? Is that something that's done just to have an idea that this person going into pregnancy, where we know the prevalence of having this be genetic component, wouldn't it make sense just to take a peek before we go through what goes through to our bodies when we're pregnant?
Oh, yes. So we do a lot of it. So I would do an MRI, full MRI of their aorta. And then I would scan them every about 8 weeks or so. I used to do them every 4 weeks, but I think I was overdoing it a little bit. But we treat them as though they have got the condition. So well, what I say to them, I offer them the choice. I say, we can either assume that you've got this condition or assume that you don't have it. And if we assume you don't have it and you have a normal delivery, this could happen. But if we assume that you do have it and we treat you this way, then we're being as safe as we can. Now, a lot of women don't want to go down the very medicalized route, and it can be quite difficult. And, you know, if they say, well, I want a home birth, we say, well, nobody's going to want you to do that. And then they want to give birth in the midwifery center, and the midwifery center doesn't take anybody with any risk. So they get a bit aggrieved about that. But then if they do have a normal delivery and nothing happens, they go, look, there you go, I told you so. But it doesn't really work like that. But I had one patient whose mother died giving birth to her younger brother. Her mother died giving birth to another brother, and her mother's sister died. So there were about 3 or 4 women in this family who had dissected their aortas in pregnancy. But she basically said, well, it's not going to happen to me. And I said, well, the way I look at it, it probably will. Sure, it certainly might happen to you. But people really have very interesting approaches. And interestingly, with her, she had 3 children, and we ended up treating her very medically for all of them. But by the time she got to the 3rd and she was a mother, she became quite upset about the fact she might have this condition. And of course, we had no DNA. So there are a lot of emotions involved, and a lot of counseling goes on about this.
Okay, thank you. Next question. So another question from a different Laura, how can we identify what teams or what centers have a multidisciplinary team that can actually handle working with pregnant individuals around the aortic disease issue?
Well, I don't know what you think about that, Halima, and it's something maybe we could discuss. In the UK, I imagine that Think Aorta helps to signpost people to the right places. Am I right?
Halima?
Sorry, I was just but yeah, I think that's one of the things that we aim to do as Think Aorta, obviously focusing on pregnancy. We want to identify where these centres are and hopefully direct all the patients into the right direction. But yeah, and obviously with our patient leaflet and things like that, we will, going forward, try and pre-identify them for everybody. So when a pregnant woman obviously becomes pregnant, she doesn't have to go looking for it. We'll have already identified it for her in her local area where she can go. But I think that's something definitely that I want to, look into and work on.
I mean, just to say one other thing about that, Karen, if I may, most people with Marfan syndrome are looked after by adult congenital cardiologists, which is what I mainly do. And that's because they're usually diagnosed in childhood. So there's a bit of an overlap there. And we tend to be quite good at, the teenagers and kind of continuity of care and so on. And we have networks. So everything is advertised on our network. So everybody in the Southwest, every cardiologist knows who to send the Marfan's patients to. And I think most networks are like that in the UK. I imagine worldwide it's very, very different. And certainly in the States, it will be totally different because things like networks aren't really quite so established, I think. So I think it's really important that patients are their own advocates and they try and find out, which is very different because, of course, that's a bit like they don't know. So I think the charities are going to be really important in trying to help with that.
And I would think that in the States, most people, when they're pregnant, they're not thinking, let me find an obstetrician who is affiliated with a hospital that has an aortic disease team. But that's exactly what they should be thinking. And unfortunately, in areas like the Midwest or more rural areas, they don't necessarily have that ease of access to an aortic disease center. That could be hours away, but it should definitely be something that's discussed with your obstetrician, that you have that plan of action, or at least you have a strong vascular team that's present in case they do need to airlift you somewhere, because it's coming more and more to me that really, I can't say the percentages, but as just a patient, I'd be thinking I have a 50-50 chance of something happening if this runs in my family, although it's not been identified in me. And I don't like any percentages. So even if you said 4%, I'm just, I don't necessarily walk around with the horseshoe. So I would want to know that in the event anything happened, I'm as close that I can be, or I have a plan of where I need to go in the event something happens.
Yeah, so I didn't specifically mention that actually, but we cover the whole southwest. So Bristol to Truro on the train, which is in Cornwall, is 4 hours. So it's a big distance, and so we advise all women to deliver in Bristol. So Plymouth is actually in the southwest and is an aortic centre, but it doesn't have the centre on maternal medicine. Mm-hmm. So we advise them also. We induce a lot of people where they wouldn't normally be induced so that they can deliver with us. But we do often have some of the scans done locally so that they don't have to come up to us every time just for scans. So that's something that can be done.
Okay. Next question. Okay. So Victoria says, "Go Halima, your AD buddies are with you, and they sent you lots of kisses, X's."
Oh, thank you.
Moira says that you are truly inspirational, Halima, and you are.
Thank you so much.
And so Lori Blake says, like mother, like daughter. She had, I guess, a daughter with VEDS that, and she just had her first granddaughter 6 months ago. So,
well, congratulations.
Congratulations.
And I think you're incredible. Thank you for all the feedback.
Okay. I know what that means. Okay, Dan Burgess, shout out to Dan. Bless you and hugs, Halima, your family, and your just your entire story. And then he said, of course, today is a good day. TIAGD.
Oh, thank you so much. Actually, Dan was the first person that I reached out to when I was actually still at the hospital with my daughter. And so yeah, shout out to Dan. Thank you so much. I think without you, I definitely wouldn't be here doing all of this work and spreading awareness. So thank you so much. I really appreciate you and everybody else in the buddy group.
Halima, people would like to know how they can get in touch with you. And that was one of the things I was going to ask. I don't know if you're aware that there is an aortic dissection support group specifically for pregnancy on Facebook. I'm not sure if you're part of that group. If you aren't, I will get that information to you because people would like to reach out to you. So if you want, we can share that information, all of your social media information.
My social media, or even my email address. And I am actually on that group. I recently joined
Wonderful.
it. I've not said much on there yet, but yeah, it's amazing to see that there's support out there.
Okay, and you know what? Aortic Hope's going to come after you too. For you to do a video or share your story in our Survivor series, we'd love to feature this information. I'm going to ask a question. Let me go back to my page of questions. So, of course, I did not have this happen to me, but I'm thinking out loud. I had preeclampsia, and my blood pressure was super high. So in the event that someone is experiencing preeclampsia, does it make sense? Do people then just do maybe just an echo on that patient before they're going to go into labor to see, you're running blood pressures in the 200s over hundreds. Would that be something that makes sense to do to all pregnant women that end up having preeclampsia?
Yeah. No, every woman with preeclampsia should have an echo. There are quite a lot of echo changes you can get actually, and we're actually doing a British Society of Echo guideline for normal pregnancy at the minute. Myself, I'm leading it, and there's a group of us in the UK, and that's a big section of it. So there are some guidelines coming in from the obstetricians about that, but everybody with preeclampsia should be getting an echo.
So it sounds like Yeah, so it sounds like, okay, if you're a pregnant person, you're a pregnant woman, you have preeclampsia, you should have an echo. If you're pregnant and you've had a family member with a known history of aortic dissection or aortic aneurysms, that obviously needs to be mentioned. That's part of what Think Aorta talks about, especially here in the States, is hashtag Think Aorta, Think Family. Share those medical details and medical history with all of your providers, and hopefully they put the pieces of a puzzle together, a potential puzzle. And I had to ask you again, because it was on your chart, how many people end up having a dissection after pregnancy or during pregnancy that did not know that there was any condition within their family because they just didn't talk about it, or they assumed that their mother passed suddenly due to a heart attack, or somebody had a stroke or diabetes in their family and they didn't attribute it to the possibilities of this?
Yeah, it's difficult, isn't it? We don't know the data on that, but certainly around about half are unaware they are at risk.
Okay.
And it alarms me, the number. I mean, some of this is historic. There's a nice paper by Diane Milovic, who does a lot of work on the MYH11 gene in Texas. And there is a paper looking at those pregnancies, and the majority of those patients didn't know they were at risk of dissection in pregnancy. So it is just a gap, I think, in patient education also.
So then part of what we talk about is if you had a family member, obviously, that has a known syndrome, Marfan, Loeys-Dietz, vascular, ACTA2, Turner, what have you. But if you don't know that there was a syndrome and you had a family member who has aortic disease, whether you're pregnant or not, you should be followed. That is a staple baseline. Now,
not just a scan, they need to be seen by somebody.
Right. Now, if you had a family member and they had a stroke or diabetes or heart disease, something that could lead to an enlargement in the aorta, and I would think, especially if you're going to become pregnant, you should mention that and at least have some baseline testing done, because those are all potential situations that can cause an aortic issue as well, correct?
Yeah, except virtually everybody will have that as sort of history because those things are so common. But obstetricians and midwives are pretty good at taking family histories. They're better than a lot of physicians who often ask, if you've got a history of family history of heart disease. But there are degrees of how good you can be at taking a family history. Genetic counselors are awesome. So all of these things are relevant. But for the obstetricians, they're thinking family history of hypertension, preeclampsia, diabetes are much more important. It won't lead them to an echo, but it will lead them to go to an obstetrician, who will then think about things a little bit more carefully, ask for cardiologist help and so on.
Okay.
But those things like diabetes and heart disease are so common that, everyone can't have an echo. I mean, people don't even get their hearts listened to in pregnancy generally.
So, and it is obvious that if somebody has a known family medical history, a person can still become pregnant. They're just going to be followed, monitored constantly.
Absolutely.
Now, here's the big question that we hear all the time that I know a lot of us shudder. If somebody's had a dissection, whether A or B, and I don't know if there's a difference, should they just rule out future pregnancies if they've had a dissection?
Yeah, I mean, they're much more likely to have problems. So there's a little comparative study and a nice editorial in JACC, I think it was, by Barbara Mulder, if anybody wants to ever look that up. Just looking at that kind of is what sort of changed the European guidelines to the most recent ones. If you've had a dissection, the recommendation is that you shouldn't get pregnant again. Now, if you've had a dissection and you've had it completely repaired, then it's a bit different. But I think if you've had a dissection like Halima and you have a continuous tail, so like a type B, but it's a residual type A, if you like, then that is not a good situation because you have a weak aorta there, and that is a contraindication. So in other words, you shouldn't be doing it. But we've had one patient do it and have a termination on medical advice, but then was very unhappy with that. And I have one woman who's going to do it regardless, but her aorta is about 54 millimeters, so descending aorta, so it's massive. So that is a bit of a no-no, but sometimes you find that this has happened to women and they've gone through. We've had a couple of those, and I've asked around the country about my colleagues about this, and they've had a couple go through that didn't know they'd had them. So we don't really know, but it just seems inherently like a very bad idea.
Can I just add there, Steph, this question for me, it sort of triggers me a little bit because
I know.
I can't have any more due to the fact that obviously I've got the mechanical heart valve, I'm on warfarin. So if I decided to go against all medical advice and still decide, okay, you know what, I'm going to become pregnant, there's a very good chance that I could possibly die and leave my daughter without a carer, but also have another child who's got a severe illness. So I can't stress enough on how important pre-pregnancy counselling is. But at the same time, I'm sort of grateful with how my situation happened, despite how horrible it was. Because if I did know all of this, I probably wouldn't have gone through with the pregnancy at all, right from the beginning. And I wouldn't have ended up with such a beautiful and amazing daughter. But now, you know, in the situation where I am now, I would encourage everybody to sort of really be aware of all of these risks before even going down it, before even getting pregnant. If you're talking about the risk of it happening, and then if it did happen, then having another child after that would be almost impossible without risking your life.
Yeah, I mean, just to mention very quickly that having a mechanical valve, just for those who are listening, doesn't mean you can't get pregnant. It just means it's high risk. But you know, the dissection is more of a concern, but it's an absolute headache because
and obviously with my condition, So I mean, for me, based on what I've been through, it's definitely a no-no for me. I'm not sure how it would work with others, but for myself, it's no, sadly. But you know, I'm happy with how it's all turned out. So yeah.
I think what this also brings light to is I don't think that most women realize how taxing a pregnancy is on a body until they're late in the last trimester going into it, let alone anybody who has a family history that may not have been identified in themselves. They don't realize the genetic component, and having a baby, housing a human being, was very taxing on our bodies in so many ways that I don't think they really teach you this in school. You don't learn about blood pressure, and you just learn about some, certain changes. But vascularly, you really are not made aware of just, it is an incredible thing. Getting pregnant and having a pregnancy is amazing. It is taxing. It is, it can be potentially scary when you have family history, and it is definitely things that you need to have conversations with your physicians, trust in a strong team to be able to get you through to being able to deliver. And I'm going to check in real quick and see if we have any other additional questions or comments. Okay, this is feedback. So Cliff says hi to all of us, and it is the first time that he's actually heard your entire story, Halima, and you're a total inspiration were the exact words. And thank you so much for what you're doing as far as education and awareness for women everywhere. And I'd say for men too, for families in general. I think that it's a very educational experience, and it's a very important conversation.
Thank you so much. And I wouldn't be able to do this without all of the support that you guys give me. So thank you so much once again. I appreciate it so much.
And Claire Payne says, what an inspirational session and webinar, and she thanks us a lot. I love Dan because Dan loves to do everything in little acronyms, but he thanks all of us, Aortic Hope, Think Aorta, Think Aorta US, ADA UKI, which is Aortic Dissection Awareness UK and Ireland, and TIA, but I can't even do it as fast as he does it, but today has been a very good day. If anybody has any questions or comments for Dr. Curtis or would like some follow-up information with Halima, you can send that information to info@thinkaorta.net. Again, that is info@thinkaorta.net if you have any other further comments, questions for Dr. Curtis or Halima. And with that, I'm going to thank everyone so much. Thank you everyone for your comments and your questions. Thank you, Dr. Curtis, so much for this extremely informational webinar. And Halima, your story is just amazing. And God bless you and your family. And I hope to talk with you again in the future. And thank you, Gareth and Think Aorta, for allowing us to help you with this webinar. It was truly my pleasure. Have a wonderful rest of your day.